So Dr. Beidas is an assistant professor of psychology and psychiatry at the Perelman School of Medicine at the University of Pennsylvania, and she's the director of implementation research at the Center for Mental Health Policy and Services Research at Penn, and also directs the implementation science working group at University of Pennsylvania. And she's truly an established, she's the go-to guru that we go to all the time for implementation science help, and seemingly is able to talk to every single one of my trainees at some point in their lives about this. So thank you.
Thank you. It is an honor and privilege to be here speaking with you today about our work. I want to start by sharing that the work I'll be presenting on has been funded by the National Institute of Mental Health through the program announcement that specifically was on firearm violence and its determinants. So I wanted to start out today by giving you a sense of what I hope to accomplish in the brief time that we have together. You can see here the agenda. And I also wanted to share with you all my lens, which is that I am an implementation scientist. So the goal of all of my work is to reduce the no-do gap and to improve the quality of health services to improve lives. So it's my hope that in this presentation today, I can begin to answer the question that Dr. Isham posed yesterday to the panel on how do we scale effective approaches to firearm promotion in health systems. I wasn't here, but I was streaming. So I'll start out by describing why I believe this problem matters. So the rate of youth suicide is increasing in our country. I'm going to say that again. The rate of youth suicide is increasing in our country. You can see here a graph provided by the CDC on rates of suicide. By the red arrow, you'll see the line that describes suicide per 100,000 youth. And what you can see is that from 1999 to 2007, we had good news, and the suicide rate was decreasing from 4.6 to 3.9 per 100,000 youth. The bad news is that that trend has reversed, and from 2007 to 2016, the suicide rate has increased from about 4 to 6 per 100,000 youth. Firearms are among the most common method in youth, particularly in males. So another graph from that CDC report, by the arrow, you can see the line that represents firearm deaths. In 2016, I just shared that the rate of suicide deaths was 6 per 100,000, and firearms are responsible for half of those deaths. And the thing is that a suicide attempt by firearm is very lethal, and usually in 85% of the time results in death. So I want to posit that firearm access is a modifiable risk factor for suicide. We know that the risk of suicide is 2 to 5 times greater in homes with a firearm, and that safer storage could save lives. So when our team started to think about this question, we asked ourselves, where could we reach the most youth if we wanted to intervene universally? And the resounding answer that we thought made the most sense was pediatric primary care, because it's really the first line of defense for our health systems. And we define pediatric primary care broadly, so that includes internal medicine, adolescent medicine, family medicine, pediatrics. The data supports that that's a good place for us to think about intervening universally. In the year preceding an attempt or death, only a third of youth visit behavioral health. Over 75% visit primary care. So the good news is there's actually an evidence-based practice for increasing parental safe firearm storage. There was a large trial done by Dr. Sherry Barkin and colleagues in 2008 published in Pediatrics. It was a randomized controlled trial of 137 pediatric practices. And basically, the long and short of it was that they had a number of violence prevention interventions within this safety check intervention. And they found that one component that was focused on firearm safe storage was effective in changing parental behavior. And there were 3 components within the firearm intervention. The first was screening for firearms in the home, providing very brief motivational informed counseling. So you've heard motivational interviewing mentioned a couple of times already today. And then giving out free firearm locks. And so basically, you can see that in this study, the intervention group reported increased storing of firearms with the cable locks that were given out with an odds ratio of 2.0 compared to the control group. Now, I want to note that this intervention was intended for parents of young children aged 2 to 11. It was really focused on unintentional injury rather than intentional injury. It was bundled with other safety interventions, including timeout, but the primary outcome was self-reported safe storage, which is a shared endpoint that we might think about for a universal suicide prevention strategy. So it's a great place for us to start when we think about implementing evidence-based practices for this to scale. So now I'm going to share some information with you all about the approach that we took in this R21 study. So the main objective and the question that we tried to answer was, can we partner with health system stakeholders to understand how best to implement the Firearm Safety Check? And I'm going to refer to it as the Firearm Safety Check going forward because we're just focusing on that aspect of the intervention related to firearms, as a universal suicide prevention strategy in pediatric primary care. And we were so fortunate as part of this project to have the opportunity to collaborate with the NIMH-funded Mental Health Research Network, of which our principal investigator, Dr. Greg Simon, is sitting in the audience. And that is a consortium of 13 health systems that are organized in a practice-based research network. So we did this study in 2 of those 13 systems, given resource constraints. The first being Henry Ford Health System with our colleague, Dr. Brian Amadani. And I'll tell you just a little bit about Henry Ford Health System so you have a sense of the context. It's situated in the state of Michigan. There are about 50 primary care practices, 1 million lives served annually, and importantly for this study, has a population of about 40% ethnic minorities, which was of interest to us. We also partnered with Baylor, Scott & White Health in the state of Texas with our colleague, Dr. John Zieber. And that was important to us, too, because Texas is a state in which gun ownership is important. And so we wanted to make sure to do our study in a place where that was true. There were about 60 primary care practices, about 630,000 lives served annually, 20% of which are under 18. And it was a mix of rural and urban practices, so we got a lot of different types of geography represented in the sample. So really in this 2-year study, which just ended a couple of months ago, we took a 2-pronged approach. We started with a quantitative survey where we surveyed physicians and leaders of practices where youth were seen about the acceptability of the intervention components and their use of those components. So just to remind you, screening, counseling, and giving out firearm locks. And then we followed that work up with in-depth interviews with 9 stakeholder groups and 70 individuals to gather more rich and nuanced information about acceptability and use, as well as barriers and facilitators to implementation. And I just want to note that all the research that I'll be presenting on today was approved by the appropriate institutional review boards. So there's 2 papers that I'm going to be describing results from in this presentation, both of which are under review. So I ask you to consider the results as preliminary until you see them out in press. So I'll start with the quantitative survey. So I'm going to focus on the physician survey, in which we asked physicians to comment on the acceptability and use of the 3 intervention components of the Firearm Safety Check. So that you can get a flavor for what I mean by that, you can see here the stem of the question. Screening would be an acceptable suicide prevention strategy in my practice, and we asked them to answer on a 1 to 6 Likert scale, where higher scores represent higher acceptability. We also asked them to comment on how often they do each of the screening, each of the intervention components, so how often do you screen? And they answered on a 0 to 4 Likert with higher scores representing higher use. Now, based on some of our preliminary work, we asked the questions twice, once about these intervention components as a universal strategy, and the second time for high-risk youth, because we were interested to see if there would be differences in how physicians responded. So I want to give you a sense of our sample characteristics. We were able to obtain responses from 71 clinics, representing 86 of the total primary care clinics in the 2 health systems. And we were able to get responses from 103 physicians, which represents about half of the physicians in the health systems serving at least 100 or more youth in the previous year. And we also received responses from 40 leaders of primary care practices, which is about 70% of the total sample. I'm going to focus today, because of time, on the physician responses. They were 60% female. Their mean age was about 44 years of age, and they'd been practicing about over a decade. And importantly for this study, 31% reported having a firearm in their home, and 13% reported that there was a youth suicide by firearm in the practice or in one of the practices that they had worked in. With regard to ethnicity and race, you can see that the majority are white, but there's a range of other ethnicities and races represented in the sample. So I'll start by describing the physician report of acceptability of the 3 intervention components. So you can see here each bar represents a different intervention component, and this is using these intervention components universally. And on the y-axis, you can see our Likert from 1 to 6, with higher scores representing greater acceptability. And broadly, what you see is that screening and counseling are rated as more acceptable when you compare them to the gun locks. And then when you look at the questions again and ask with regard to high-risk youth, you can see that the acceptability increases by about a point, where physicians report that all 3 intervention components are more acceptable for high-risk youth. I also want to share some of the data on physician self-reported use of each of the 3 intervention components. And so basically what you see here, again, are the 3 intervention components. And if we use a less conservative criteria, 85% and 80%, sorry, let me start that over. If we use a more conservative criteria where physicians could endorse that they rarely or sometimes used each of the intervention components, you'll see that 85% of physicians reported using screening, 80% reported using counseling, and a much smaller percentage, 9%, reported giving out gun locks. Now, if we were to make the criteria a bit more conservative and only report on the percentage that endorse using these intervention components most or all of the time, you can see that that number drops pretty substantially to 28% of physicians endorsing using screening and counseling most or all of the time, and only 2% with regard to gun locks. So just to briefly summarize the quantitative survey, screening and counseling seem to be highly acceptable, commonly but not routinely used in pediatric primary care, and firearm locking mechanisms seem to be less acceptable and rarely used. And this is a problem and something we should keep in mind as I talk about some of the qualitative data, because previous studies and a systematic review actually that Ali did suggest that the free safe storage devices may be the critical ingredient. And so we need to figure this out before we go forward in a large-scale implementation. So now we'll talk a little bit about our qualitative data. So as I mentioned before, we had the opportunity to do 70 semi-structured interviews with 9 stakeholder groups represented in the smaller boxes above. And you can see that we tried to talk to everybody who might be impacted by the large-scale implementation of the Firearm Safety Check. So we talked to parents, physicians, nurses and nurse practitioners, leaders of primary care, behavioral health and quality improvement, third-party payers, leaders of national bodies, and a later addition, once we started really thinking this project through, we talked explicitly with gun owner constituents, because we wanted everybody's voice to be heard in this research. So in addition to the 12 folks that we talked to who fell in the gun owner constituents box, and I'll tell you a little bit more about them when we get to the results, we also collected gun ownership information from 3 of the stakeholder groups, parents, physicians, and leaders of primary care. So you can see that there's good representation of those folks who have firearms. So in our interview, we were broadly interested in gleaning 5 major themes in the questions that we asked. The first pertained to the role of pediatric primary care in suicide prevention, firearm culture in the communities that were served by the health systems that we were working in. We wanted to get more detailed and nuanced information about acceptability and feasibility of the intervention components, particularly the firearm locks, as well as barriers and facilitators to implementation, and who should be responsible for implementing the 3 components of the Firearm Safety Check. I told you I was an implementation scientist, so true to my word, we used a popular implementation science framework in thinking about our interview questions called the Consolidated Framework for Implementation Research, or the CFIR. And the CFIR helped us think about the multi-level ecological context that we would be implementing in, and encouraged us to think about asking questions related to intervention characteristics, the outer setting, which refers to the broader socio-political context of the implementation, the inner setting, which refers to the organizational context of the health systems, the individuals involved in implementation, and the process of implementation. So the sample that I'll be presenting on here includes some of the physicians and leaders of primary care practices who completed our quantitative survey, but includes a number of other stakeholders. The sample was 56% male and a mean age of 47 years. And you can see the raw data here for ethnicity and race, and once again, predominantly white, but also other ethnicities represented. So I'll start by describing some of the outer setting themes related to firearm culture. So it's no surprise to everybody in this room and everyone watching that firearms are a politically divisive topic that can raise concerns around Second Amendment rights and illegal ownership. So we heard our stakeholders across stakeholder groups describing the issues related to having physicians and health systems ask about firearms. I think this quote is a nice exemplification of that. One behavioral health leader said, "So we're talking about coming into a culture trying to do a very reasonable urban intervention on a mostly rural population that is politically very, very, very charged around gun rights." Interestingly, we heard from a number of stakeholders that recent high-profile gun-related incidents, such as Sandy Hook or Las Vegas, are making it easier for clinicians to initiate these questions. We also heard a number of inner-setting themes, and I'm going to focus on the ones that are most relevant as we think about health system implementation because of time. So we heard about the importance for system buy-in and alignment with priorities if we were to go forward with large-scale implementation. A leader of primary care practice said, "I think the health system is really good about standardizing things and rolling it out, but at that top level, if that level is not sold on it, then nothing will happen." We heard a lot about the characteristics of the individuals involved in the implementation, mostly pertaining to their knowledge of firearm safety promotion, their self-efficacy and confidence in implementing those interventions, and also the need for them to engage in a non-judgmental stance around firearm safety promotion. There was variability in the comfort in those we talked to in how much knowledge and how much confidence they had in talking to parents about firearm safety. With regard to who might be tasked with implementing each of the three components, the message was pretty clear that there was a feeling that nurses or medical assistants could do screening and give out firearm locks, but that physicians should be doing the brief counseling. We heard a lot about the intervention characteristics related to the firearm safety check. Starting with the screening and counseling, just to build a little bit on the quantitative data that I presented, the qualitative data largely corroborated what we saw in the quantitative data. There's a lot of acceptability and feasibility around those two components, and there were good suggestions about how we might think about using the electronic health record to prompt for screening and giving written resources for safe storage recommendations to support the counseling process. You all might be wondering about, the quantitative data I presented on the firearm locks, and I think that the qualitative data really elucidates some of the challenges with that intervention component. So there are concerns about how to pay for, how to store, and how to distribute firearm locks, and a minority of participants described concerns about liability. If a parent uses a firearm lock incorrectly that I gave them, am I liable for that? And there were some interesting suggestions about referring patients to get free locks in the community rather than distributing them in the hospital or in the primary care setting. Other themes that I think are relevant for this audience include some of the main barrier that came up, and I know this is something Megan Rainey described yesterday. If a primary care doctor were to do all of the things that they're asked to do around prevention, it would take 8 hours, is time. So there was a description of a real need of being thoughtful about making these interventions easy, brief, and and giving out resources that could cut down the time associated with them. With regard to facilitators, there was a lot of discussion about how integrating these approaches into the electronic medical record could make implementation smoother, and also integrating into existing initiatives such as zero suicide or integrated behavioral health. So this data is even more preliminary, and we're still working on really drilling down into the qualitative interviews that we did with gun owner constituents, because we realized that we needed some additional codes to capture the perspectives of the gun owner constituents, because there were new themes emerging from what they told us. And just so you have a sense of what this group looks like, these were individuals in law enforcement, law, firearm advocacy groups, firearm safety course instructors, and firearm retailers. So they too had some concerns about the intervention characteristics, but it was a little bit different than what we heard from the healthcare system stakeholders. They were very concerned about screening and documentation in the electronic record. So there was a sense that perhaps documenting firearm owners in the health record could result in a national registry, and that it's not necessary to do screening to do the other parts of the intervention. And actually, that's quite consistent with the ethos of the initial intervention that Dr. Barkin developed. She would ask about screening, but then still ask the question, how many firearm locks do you need? So we have to think about documentation to ensure that it's meeting the needs of these stakeholders. Another theme that emerged was a lack of trust and a feeling that the public health platform is a disguise for firearm control. And I think we really need to heed this message and attend to it. And on the same side of that coin, the need for partnership, which may allow us to heal that rift and to build trust. So our gun owner constituents suggested that it would be critical for health systems to think about partnering with firearm safety experts, such as safety course instructors, who are more credible and knowledgeable to firearm owners. And so that is another piece that I think we have to attend to. So I'll conclude in the time that I have left with some implications for health systems. So some good news, as part of this work, we generated a list of implementation strategies that we hope to test in a future trial. I won't have time to get into all of the different components of this, but if you're interested, I'm happy to talk more. For example, thinking about creating a plan for whom on the medical team would be responsible for implementation, or integrating the intervention into the electronic health record to provide a nudge to increase fidelity to the intervention. Second, we all want to keep youth safe. That is our shared agenda. This is about firearm safety, and this is not about firearm control. And that message needs to be the message that underpins all of this work. One of the insights that I've gleaned is that it's probably going to be necessary, and it's exciting to me, to expand beyond thinking just about suicide prevention. If we're going to be taking a universal approach, we should be thinking about unintentional and intentional firearm injury prevention so that we can make it most relevant to the broadest swath of the health system. The Firearm Safety Check is feasible, acceptable, and ready for implementation based on our study. Now, it does need some tweaks, so I acknowledge that, but I think that the time is ripe, and I might ask, what are we waiting for? We know that there's something that works, and we should be thinking about implementing it and testing the success of that implementation. Now, it's clear to me that there needs to be adaptation to the intervention as it is. We've heard a lot about how cable locks are not as acceptable to firearm owners, and there are different ways to think about locking firearms up to keep kids safe. I was really excited to see Dr. Emmy Betts present on her Lock to Live study yesterday, and we could think about incorporating decision aids into the intervention so that parents can make informed decisions about which locking mechanism makes the most sense for them. If you only remember one thing from the presentation today that I've made, it's that we need to partner. This cannot be about docs versus glocks. One of my favorite examples of a partnership that I think has so much potential for us to be thinking about moving forward is one that Kathy Barber at Harvard has with New Hampshire gun shop owners. There's a paper she just published on it that I highly recommend as reading. And I think this really maps on nicely to what Emmy said yesterday. If we want to be trusted, we need to leave our politics outside of the exam room and work together around these issues related to firearms. And I'd go even further to say we must hear the voice of all stakeholders, not just the ones we want to hear. So with regard to future directions, there's still a lot to learn, and I'm excited that we're here thinking about a research agenda. I think there's a lot of questions around how best we partner with firearm owners around a shared agenda and build trust. There's questions related to how we adapt the intervention to optimize its effectiveness and whether the intervention should be universal or targeted. I still feel like it should be universal because that has the potential to have the largest public health impact, but I want to make sure that we're listening to all the voices. We need effectiveness trials with more rigorous endpoints. So in the large trial that was very well done that I presented, the endpoint was self-reported parental safe storage. And we need other endpoints such as checking actual safe storage and or firearm injury. And finally, near and dear to my heart, we need large implementation trials testing different implementation strategies to see what results in the best uptake. So I want to conclude with gratitude because without the people listed on the next slide, we could not have achieved what I shared with you all today. That includes my lab, our funder, our many partners and the participants, and co-investigators and study staff. Thank you so much for your attention today.
Thank you, Dr. Beidas.